Continuing on with our renal failure patient, the next issue we need to discuss is metabolic acidosis. Typically, it is the job of the kidney to excrete excess free acid ions into our urine, and that's actually what makes our urine acidic, which is good. We need acidic urine. But that's where we get rid of all of our excess acid, is by literally voiding it out. However, these kidneys are not working the way they are supposed to, so the kidney will not excrete that excess acid. That means that your patient is going to be in metabolic, because it's the kidney's fault, acidosis. But that's not it. There's an additional issue. The kidneys are supposed to reabsorb bicarb. That ability to reabsorb bicarb meant that you had more buffering ability if you did have acid. Well, not only is the kidney hanging on to acid, it's failing to reabsorb bicarb. So we don't even have the buffers there to help us out. Now, your lungs will attempt to help this out by compensating for the excess acid, knowing that when we exhale, the CO2 that's exhaled is actually an acid in the form of an acid. The lungs will compensate by trying to blow off that acid. That means your patient's respirations will likely be rapid and deep. We normally think of rapid and shallow, but this will be rapid and deep. What are some signs and symptoms of metabolic acidosis? Well, headache, lethargy, and then confusion and delirium. So these are definitely some symptoms that we would like to avoid. The next issue we want to discuss is fluid balance. Well, we've mentioned a few times now, your patient in renal failure is going to be hypervolemic. They're hypervolemic because of their inability to excrete excess fluid. And you have to think about where all the sources of body water. We always just think of the fluid that we take in, okay? We do take in free fluids in our diet, for sure. But some of the foods that we eat themselves have water. Fruits and vegetables definitely have a fair amount of water. Even lean meat has water, okay? But we also make water in metabolism, especially glucose metabolism. And handily enough, a renal failure patient, we'll talk about why in just a little bit, they are usually on a protein-restricted diet. So many of their calories are going to come from carbohydrates. So the more carbohydrates you are metabolizing, the more water you're going to make. This can lead to the symptoms of congestive heart failure because the patient's going to have all that fluid they're trying to push around. And we all know that if the body can't deal with all that fluid, one of the first places it likes to tuck fluid is the lungs. The lungs are almost always where that happens. So your patient may actually suffer from a little bit of pulmonary edema. That pulmonary edema is going to decrease their ability to have good gas exchange. So it's going to decrease the oxygen coming in, but wait for it, it's also going to decrease their ability to excrete CO2, which is what was supposed to be helping us out with that metabolic acidosis deal, right? Okay. The treatment for this fluid balance issue is fluid restrictions. So a lot of times they will be on a restricted amount of fluid. Diuretics, but I say that one tongue-in-cheek because if they're in the early stages of renal failure and they still have 10% of their kidney that's functioning, you might get a little bit of benefit from giving diuretics because there'll be a little bit of kidney that'll actually be working. But as you're further and further down the line, diuretics are irrelevant. There's nothing working left in the kidney for the diuretics to act on. And then last but not least is dialysis. Of course, if we cannot get the fluid off any other way, the patient could literally drown in their own fluid. So if it comes down to it, we may have to try and just put them on dialysis. If they're in acute renal failure, we do try to avoid this, but sometimes we can't. If they're in chronic renal failure, they're going to end up on dialysis at some point. It's just a matter of how long we can keep them off of it. I know you haven't had endocrine yet, but I know you were perfectly capable of understanding the idea of insulin resistance, okay? Many patients who are in renal failure are diabetic. They literally go hand in hand. I'm not going to say every patient that is in end-stage renal failure is diabetic, but the bulk of them are. Well, what happens with renal failure is the cell membranes that the insulin is supposed to respond, the cell membrane is supposed to respond to the insulin and then let the glucose in. Those cell membranes become more resistant to insulin. They kind of look at it and go, no, I'm not doing it. I'm not going to do it this time. So then the body has to respond by creating more insulin to kind of overwhelm it and like gang up on the cell membrane and say, but you're gonna. But it takes a lot of insulin to do that. What that ends up meaning is the patient's serum glucose is going to be elevated because they're probably diabetic. They're probably taking in a lot of sugars because protein is limited, and that also makes their insulin levels go up. If they're a type 2 diabetic and they're making any insulin, their own insulin levels will go up. If they're a type 2 that's actually taking insulin or a type 1, then that means we are going to have to elevate their insulin levels. So that doesn't sound so bad, right? Just give them more insulin, the sugar will eventually, or the insulin will eventually overwhelm the cell membrane and the sugar will go into the cell and everybody's happy. Except that when we have that much insulin in the body, it's called hyperinsulinemia, and it has a little side effect. It stimulates triglyceride production, and not by a little bit. It stimulates it greatly. And I don't mean the good triglycerides. I don't mean the healthy DLs. No, I mean the LDLs and the VLDLs, the low density lipoproteins. What that means for the patient is that is going to accelerate the atherosclerotic processes. So basically the plaque formation on the inside of the vessel, that process is going to step up. It's going to form faster and faster. So that's going to compromise circulation because no matter where we're talking about in the body, you need good circulation. If there's any of the kidney working, that atherosclerosis is going to damage what's left because it's going to be like going into the glomerulus and painting it with, fat and then saying, yeah, now you try to get through this. You try to get back and forth through here. And then it's going to happen everywhere else. It's going to happen in the heart, which obviously is dangerous and puts us at risk for, cardiac events, but it happens everywhere. And wait a minute, aren't diabetics already known for having pretty crappy circulation to begin with? And now we are actually going to make that worse. That hyperinsulinemia that is going to be a necessary evil to get glucose to go into the cell is now going to cause increased triglycerides and more plaque or atherosclerosis. But wait, there's more. They also become anemic. We know that normal kidneys produce EPO, and EPO's job is to go to the stem cells in the bone marrow and say, hey, we're getting a little low on red blood cells, how about you make some for me? But of course, in this instance, the kidneys are failing. So failing kidneys produce little to no EPO. What that means is you don't have that catalyst going to the stem cells and saying, hey, make some red blood cells. But that's not the only reason. I've mentioned a couple times, and I'll explain the rationale shortly, that patients who are in renal failure have to follow a low protein diet. That low protein diet means that they're not getting very much protein. So if they're not getting very much protein, you're not going to have a lot of protein to spread around to make white blood cells, red blood cells, whatever, even to heal tissue if they've got some kind of wound. So it's going to result in everything not being given exactly what it needs. You won't have as many epithelial cells being made, white blood cells, platelets, or red blood cells. And by the way, if you're giving patients only a little bit of protein, you want to make sure it's good protein. It's got, all the essential amino acids, it's good, high biologic value. That's the kind of protein that you want to give your patients. But wait, there's more. The toxic environment that those red blood cells are now attempting to exist in is going to impact their lifespan. Normal red blood cells in a normal patient are going to last 90 to 120 days, 3 to 4 months, okay? For your patients who are in renal failure, you can cut that in half. So we're talking 45 to 60 days tops. But wait, there's more. When those red blood cells then get exposed to this toxic environment, they hemolyze, or they break down, they go into hemolysis. When those red blood cells break down, their breakdown product is bilirubin, okay? Now, that bilirubin that level is going to go up. Where do we normally, after we conjugate, get rid of our bilirubin? In our urine. That's one of the things that makes our urine yellow. So, we are not voiding out very much urine. That bilirubin level is going to start going up. Of course, what adds to this is when our patients are anemic and we can't just, get them to make their own red blood cells, a lot of times what we'll do is give them a blood transfusion. So we give them an instantaneous transfusion of blood, which probably is going to help their oxygenation a whole lot, but we're still putting those cells into a toxic environment. And that just means there's even more red blood cells then to break down and create even more bilirubin. That has to be dealt with. If bilirubin levels get too high, I don't have to tell you what's going to happen. I know you haven't had GI yet, but you know that elevated bilirubin leads to jaundice. So your patient is going to start having liver issues. They're going to start turning yellow. So all of these things are going to start compounding on themselves. Now there is a new drug called Epigen or Procrit, which is genetically engineered EPO. So we can actually give our patients EPO, but that is only a small portion of the problem being taken care of, because if they don't have a ton of protein to make those red blood cells, and those red blood cells that they're making are still in this toxic environment, we're still going to have not enough red blood cells, and we're breaking them down and making more and more and more bilirubin. Are we having fun yet? The next thing we're going to talk about is immunologic function. I just mentioned that we have a low protein diet, and because of that, we don't have a lot of protein to go around to make red blood cells, white blood cells, platelets, all the like. So, without as many white blood cells, our inflammatory response is decreased. What that means is if the patient is exposed to an infection, we're not going to see that overwhelming inflammatory response initially to clue us in that it's there. So by the time we figure out the patient has an infection because of that diminished inflammatory response, it's probably going to be a raging infection. And then we're going to need something really, like some type of really strong antibiotic. Really strong antibiotics tend to be, what? Did you say nephrotoxic? I hope you said nephrotoxic, because they are. And they also have to be metabolized by the liver, which the liver is, of course, busy dealing with all this excess bilirubin. So that's going to be problematic as well. But this is absolutely necessary for the patient to have a low protein diet, because protein breaks down into urea, and the patient cannot excrete the urea on their own. So the more protein they have, the more they need dialysis and all these other things. And obviously that has its own set of issues, which we're about to dive deeper into also. But that means that there's fewer white blood cells laying in wait to stave off an infection, and there are fewer white blood cells to create that non-specific immune response, that inflammatory response, and let us know that something's set in. This increases the possibility that that infection will be a much bigger one. So the patient's potential for infection when they're in renal failure goes way up. We're going to put cardiovascular and pulmonary kind of together because they're going to relate to one another. But the three main issues that are going to come about in patients in renal failure due to cardiovascular or pulmonary issues include hypervolemia, that shouldn't be too difficult to figure out, hyperkalemia, talked about that, and hypocalcemia, talked about them all, right? Yeah, but now we got to relate it really back to the heart. Hypervolemia is a significantly increased volume. that's going to be hard on the heart. That means the heart is going to behave like the patient has CHF, and it's going to make it very hard to contract or pump that fluid around. Usually, in a situation like that, one of our outcomes ends up being pulmonary edema because there's just so much fluid. Well, we would normally treat a CHF patient with digoxin, okay, to increase the contractility of the heart, which is a cardiac glycoside. But digoxin is one of those ones that is very sketchy about, being in a certain range. You've got to make sure you don't get toxic. Well, it's hard to not get toxic on a drug when you really can't excrete it because dig is excreted through the kidneys. So that's going to be a very difficult thing to manage. And then you've got the pulmonary edema. And we'll go ahead and give Lasix. Oh, wait a minute, Lasix. That probably won't work very well, especially if we don't have very much of the kidney still working. So now we don't know exactly what's going to be helping with this pulmonary edema. Usually what ends up happening is they need dialysis because that's the only other way that we can pull that excess fluid off the patient. Then we have hyperkalemia. We talked about the risk already of fatal arrhythmias or dysrhythmias, but then when you have the heart already trying to deal with being super saturated with potassium, and of course we know that sodium and potassium pump has to work just so it all works out, then you add on top of that a ton of fluid that the heart has to deal with, and then maybe having to take medications like those cardiac glycosides. We are setting that heart up for a potential dysrhythmia that could be very, very bad. So hyperkalemia is also going to be very impactful. The final one that we're going to talk about is hypocalcemia. Hypocalcemia is going, we've already talked about that with demineralizing the bones and twitch CC, Shavastic centrosos. Well, that whole twitch CCs thing, that's muscles, right? Is the heart a muscle? So basically what's happening is when the calcium level is low, it increases the irritability of the heart muscle, making it kind of want to twitch and do kind of crazy things to begin with. That also means you don't get a nice solid contraction of the atria and the ventricles. It might be a little sluggish, or it might kind of do it weird. So that decreases the contractility of the heart, which is then going to feed back into making that hypervolemia problem even worse. So these three things together just feed off of each other, and they make this a potentially dangerous situation for your patient, both cardiac, obviously with cardiac issues, but with pulmonary side effects as well. The neurologic side effects can sometimes be a little hard for students to kind of grasp initially. So we're going to try to take this one step at a time. Some of the neurologic changes that you will see can be just simple mental status changes that you will see with changing electrolytes and acid-base balance. When electrolytes are off or acid-base balance is off, your patient can have some changes in their mental status. But that's not all. Just like those red blood cells I mentioned, they didn't like the hostile, kind of nasty, funky environment of all those nitrogenous wastes. Neither do your nerves. So those little fine nerve endings that are in your periphery, the ones that give us all of that, those fine motor and feeling abilities, they don't like it either. So the problem is that nasty waste-filled blood starts to affect the nerves as well. Your diabetic patients already get peripheral neuropathies, right? That's one of the side effects of diabetes. Yeah, but we get to add more to that. So their peripheral neuropathy is going to be even more pronounced if they're in renal failure because the nerves are being damaged related to that toxic environment. All right, here's the one that's a little bit hard to understand, disequilibrium syndrome. What you have to think about is the blood-brain barrier. Even though there is communication between the blood and the cerebral spinal fluid, it's not easy. Things can diffuse in, diffuse out, osmose in, osmose out, but that barrier means it makes it kind of difficult for it to do that. So the issue is, When a patient is on hemodialysis, before they end up going to dialysis, their body is filled with a ton of wastes, just a lot of them. And at that point, the body's like a squirrel, at wintertime, just trying to find some place to tuck this stuff in because it can't get rid of it. So it's like, trying to, oh, I want to get rid of this, let me shove it under the couch, let me shove this under a chair cushion. The body's kind of like, well, let me shove it here, let me shove it there. Well, one of the places it will try and eventually succeed at shoving those extra waste products is into the cerebrospinal fluid. But the issue is, it'll still be balanced. There'll be balance between the osmolarity of the cerebrospinal fluid and the osmolarity of the blood. However, when we do hemodialysis on a patient, we, in 3 to 4 hours, to simplify it ridiculously, I'm just going to say we clean the blood. So it's like going in there with a massive shop vac and cleaning that blood all up and getting it all nice, shiny, and wonderful. Yeah, but it didn't reach to the cerebrospinal fluid. The blood-brain barrier did not allow that to happen. So then the issue ends up being, we've cleaned up the blood. The blood's great. The osmolarity of the blood is now back down where it's supposed to be, but the osmolarity of the cerebrospinal fluid is not. And we've learned a couple of times now that when there's a shift in osmolarity, fluid moves to the area of higher concentration of particles because water only has the power of dilution. So what will happen is fluid from the bloodstream, serum, will then osmose across that blood-brain barrier, and it will begin to try to dilute what's on the other side. What that means is we're going to have, it won't be terrible at first, but we're going to have basically some fresh onset cerebral edema. That's going to cause some major mental status changes in your patient, and it's going to be very, difficult to deal with initially. That's called disequilibrium syndrome. Now we have a treatment for it, and that treatment is to administer into the bloodstream something called hypertonic glucose. So it's an elevated amount of glucose, not just a regular amount. Because what we're trying to do is prevent that fluid from shifting. If I put glucose into the blood, then the blood is going to have a more similar osmolarity as the cerebrospinal fluid, and we won't shift any more in, and it might even go high enough that we start shifting it back out, okay? So that sounds like a good plan. That's a good idea. Except that eventually that hypertonic glucose, that glucose has to be dealt with. Well, your cell membranes are resistant to insulin. So to deal with that glucose, we're going to have to give a ton of insulin to get that glucose to eventually go into the cell. When we do that, we're going to put your patient right back into a state of extreme hyperinsulinemia. Hyperinsulinemia increases your triglycerides and the production of VLDLs, and that's going to accelerate the atherosclerotic processes in the entire body and negatively affect the perfusion everywhere in that patient, who's diabetic probably. So, yeah. If you're feeling a little frustrated at this point in time, then I would say that's good, because that means you understand how frustrating this is for the patient as well. It seems like nothing that we do fixes anything, and even the things that we have that try to palliate, they cause other problems in the long run. Let's talk about skin. So I mentioned before that the uremic frost that comes out on the patient's skin is a precipitant of calcium phosphate crystals. Those crystals and the urea will accumulate on the patient's skin because that's the only method the body has to try to get rid of any of it. This is like the equivalent of excreting sandpaper out of your pores. So this is going to cause dryness related to decreased oil gland secretion. The skin will take on a pale gray color because of the uremic frost, but if they've also got a little jaundice mixed in with it, it might be a gray to pale gray yellow kind of color. This uremic frost is very itchy, and it causes dry skin, which dry skin is itchy as well. So before long, you got a patient scratching, and they're scratching. It doesn't take long for the dermis or the epidermis and the dermis to be injured by all the scratching, and then before you know it, you've got potentially some open sores on the skin. But, that's okay. We've got an immune system. Oh, wait a minute. We really don't. We don't have a really good immune system. So if any of those openings on the skin and any skin bacteria get into those openings, we really don't have a good inflammatory response to let us know that it's happening, and we don't have a fantastic immune response to subvert an infection before it would ever happen. So I think you can see how one problem can compound on the other. The way that we have to deal with uremic frost is to actually dilute it, meaning you can't just use soap and water. Soap and water is going to basically leave those sandpaper crystals on the skin, and as you're bathing the patient and rubbing over the skin, that sandpaper, the crystals, are going to be scratching the epidermis. So what we need to do first is use a dilute vinegar solution. And we're literally going to put vinegar solution onto a washcloth and kind of lay it in spots and then wipe gently, and that will dilute and dissolve the uremic frost. Then once the uremic frost is gone, we can actually bathe the patient, and then we will come back and apply like a lanolin type lotion to combat the dryness and the itching and all that kind of stuff. Now we'll talk the GI system. I mean, literally, guys, there's no body system that isn't affected in some way. We've already mentioned that patients who are in renal failure have to be on a low protein diet because protein breaks down into urea. Urea then is floating around in the bloodstream, and that's what causes that uremia that we talked about before. Urea, when not excreted, is then further broken down into ammonia. That ammonia can build up in the GI tract, causing irritation, nausea and vomiting, bleeding, and sometimes a metallic taste in the mouth, okay? I think you can imagine why we don't want a lot of irritation, because if we have bowel irritation, do we have a lot of white blood cells to go to the area to have an inflammatory response and help repair the tissue? Oh, and do we have a lot of protein to build cells to repair the tissue? And then if they're bleeding, they're already anemic, they're losing more blood, and will be even more hypoxic potentially, and that's going to set up other problems as well. So neither one of those situations is great. So I think you can agree that a low protein diet helps to keep us out of that situation. So if we can't have protein, we're probably going to fill more of their plate, obviously, with complex carbohydrates. So a diet high in complex carbs and low in protein reduces ammonia, but complex carbohydrates break down into glucose. And glucose requires insulin to get into the cells, of which the cell membranes are now going to be a little resistant, so it's going to take a gang of glucose or a gang of insulin to help get it in there. And I'm sure you remember how that song ends. This whole thing, it's like everything we do to fix one problem might actually contribute to another. So you can see, the frustration not only of the patients but the healthcare workers trying to make a positive difference in this person's life. One thing I forgot to mention on the previous slide was if your patient has that metallic taste in their mouth, make sure that you don't offer them metal utensils. That makes all their food just taste like metal. So if your patient's complaining of a metallic taste in their mouth, give them plastic forks and spoons and whatnot, and that will help with that tremendously. Okay, now I need to talk about musculoskeletal. Musculoskeletal is affected by renal failure by actually putting a patient into something we call renal osteodystrophy. Renal osteodystrophy is characterized by 3 separate processes. The first is metastatic calcification. And that's when, remember those calcium phosphate salts I was telling you about? They don't just come out on the skin. They do come out on the skin and make uremic frost, but they're not limited to that. They can deposit themselves in the patient's vessels, which then can be even more of an obstruction, or it could be the seed of potentially a DVT. They can deposit themselves in the joints, making mobility more of a problem, in the muscles, in the lungs and in the eyes. You can actually look, on their sclera sometimes and see these calcium deposits. The next thing that happens is called bone demineralization. This is in direct response to the body trying to deal with this hypocalcemia situation. Because normally, all the body has to do when it needs a little calcium is have parathormone harvest a little bit from the bone. So what basically happens is parathormone goes to the bone and says, hey bone, break down a little bit so I can have some calcium. So those osteoclasts, I know this is a throwback to physiology, but those osteoclasts come in and they break the bone down and they mobilize the calcium so parathormone can have it. Well, the problem is we know what happens to that. It's still going to make more calcium phosphate salts if we haven't lowered the phosphate. But the next thing that's going to happen is there won't be additional calcium to put back in the bone to replace it. So what we will replace it with is cartilage. The osteoclasts break it down, and instead of osteoblasts building the bone back up, chondroblasts build it back up and try to fill it in so that there's something there, but we know cartilage is not strong like bone, so this is where we start having bone density issues as well. So when large amounts of calcium is removed from the bone and replaced with fibrous tissue like cartilage, that's called osteitis fibrosa. So the three things together, the metastatic calcification, the bone demineralization, and the osteitis fibrosa, all go together to be renal osteodystrophy. And most patients who are in renal failure have renal osteodystrophy. Finally, we're going to talk reproductive and endocrine. We don't know exactly why. The theory is the toxic environment of the body will basically start doing damage or decreasing the function of the thyroid gland, because for some reason renal patients, and we can't think of any other reason why, renal patients usually become hypothyroid, okay? Then hypothyroidism oftentimes results in decreased production of sex hormones, okay? Now, the bad environment, the toxic environment of the blood is also going to contribute to that. So between those two things, most patients in renal failure, if it's a male, they'll stop producing sperm. They just won't produce it anymore. It's like the body realizes you're in no shape for reproduction at this moment. And the same thing with a female. If they haven't hit menopause yet, then the likelihood is they'll stop having periods because of the renal failure, and they certainly won't be ovulating and things like that anymore as well.